Hello, I'm Matthew Gavidia. Today on MJH Life Sciences News Network, the Center for Biosimilars is pleased to welcome Jim Koeller, who is currently professor of pharmacotherapy and member of the Center for Pharmacoeconomic Studies in the College of Pharmacy at the University of Texas at Austin, where he holds the Eli Lilly C.R. Sublett Endowed Fellowship in Pharmacy. So, as more biosimilars are approved, what's happening on the prescribing, treating level with respect to payer pressure to use biosimilars?
That's actually a good question. Again, I think most people realize that health insurance covers most of the things that we do these days. Um, and he who pays, I always have a saying when I talking to my students, he who pays makes the rules. And people have to realize most of the medical care we get today is actually paid by our insurers. Yes, there are co-pays, but even now with a lot of the medications, the industry has come up with ways to help cover some of those co-pays, but the majority of cost of healthcare, hospitalization, visits, and drugs are still made by the insurers. Now we pay for that insurance, or our employer pays for the insurance, but the real purchaser of most healthcare are the insurers, not the people. So when there are these big choices to be made on what kind of drugs or the type of drugs to be used by, let's say, an employer like United Healthcare that insures 77 million lives, and they're the ones paying, they have the power to choose and have their own formularies to say, as United, we will cover this drug. And we're seeing that now. A lot of this came through with hepatitis C. When the hepatitis came through, and the new antiviral drugs were hundreds of $100,000 to cure someone, but there are a lot of people with hepatitis. What the insurers did is they bid against the various companies with those agents to bring down the cost from 60, 80, 90,000 down to 20, 30, 40,000, which is a big savings in cost. So they would say, we're going to pick this combination as our choice to treat hepatitis. Now understand, the drugs that they were picking are oral therapy. And oral therapy can be dispensed from any pharmacy. It's relatively easy. So I think that was one of the big starts in how insurers have their own formularies, and they can pick those drugs that they do deals with the industry. But then if I have United Healthcare patients in our system, we would have to use their drugs because that's what they're covering. Now, that's not such a big deal when you're just dispensing them out of a pharmacy, and I can get a variety of oral drugs in our pharmacy. We can dispense them. When you see the problem occurring is when they try and do the same thing with injectable drugs. And a lot of these biosimilars now are injectable drugs. And again, the whole intent of a biosimilar was to bring a version of the originator's biologic to market at a cheaper price. The biologics are hugely expensive. They've been one of the highest costing groups of drugs that we have in healthcare as armamentarium. So there's always been a push to try and get the cost of these expensive biologics down. Biosimilars actually fit that bill. But now if an insurer picks one of the originator drugs to say, I need you to use this agent, and it may be I only have a small percent of my patients through that insurer, that could dictate all my patients. If I now have to use their drug for, let's say, 10% of my patients, they're dictating 100% of use of drug in my institution based off of their 10% of patients that I actually need to give that drug to, because I may not want to keep various versions of that drug on board. The difference is it's easier to dispense oral drugs of multiple kinds from a pharmacy. You get bottles. But injectables, I have to have the injectable, I have to have the order sets, I have to be able to keep inventory. The drugs are mixed up. We mix them up with technicians, give them to patients. To have more than one version of an injectable drug in a system, in a health system, is a difficult thing to do. No one wants to be able to do that. We want a single version of an antibiotic. We want a single version of a growth factor. We don't want three or four. It's very complicated to manage those within a hospital. So the insurers can have a big impact on these injectable biosimilars. We've already seen now that United is picking what they call preferred agent, which means this is our agent that's part of our formulary, that if you have a United patient, you need to give them this biologic. This is the one we pick. That may not be the biosimilar, and it may not be the biosimilar I want to pick based off of the deal our institution can get for that drug. So the payers can actually force us into products that we may or may not want to use. So they're calling the shots, we are not. So that can, as you can see, that can create a problem and certainly logistical issues for how you're going to approach that.
Beyond payers, is the pressure to use individual biosimilars coming from anywhere else?
Well, I think in general, as I said, if you look over the last numerous years, the rate of rise of biologics has gone up 15, 20% every year. Typical pharmaceuticals go up 7 to 9% every year. So a lot of the healthcare cost in drugs is related to biologics, to these expensive biologics. So there's always been pressure in institutions to bring down drug budgets. When a certain class of drugs are driving a lot of that drug budget, there's always been pressure to, are there less expensive ways to do this? And as I said, the biosimilars now offer a less expensive version of that more expensive biologic agent. So I think just in general, there's been pressure to bring down the cost of drugs used in general healthcare. And the biologics are at the top of the heap of most of those expensive drugs. On top of that, we've had recent action by Medicare through their oncology care model for us people in cancer, and through QPP, which is the quality payment program now that anyone taking care of Medicare patients has to manage. Medicare, as you know, is in trouble. We have what are called the baby boomers, me, our age group, coming like a freight train. There are 3 million people retiring every year in America. We haven't reached the peak yet, but you're going to have 70 plus million elderly Medicare patients for you younger taxpayers to pay for. And Medicare has been looking at ways to bring down the rise of cost of care for Medicare. As part of that program, they've now trying to move away from volume to value. Historically, if there's a code for a procedure or a drug, and a physician writes that code, writes that for a patient, that Medicare patient would get it. So there was a lot of things being given with no real limits on that per se. Now they're moving to more quality and value versus quantity. So value is, can I do a procedure? Can I give something that's equally effective at a lower cost? Outcome over cost equals value. So they're trying to get more value, more cost-effective treatments and therapy and care into the VA system, just because of the expansion of what Medicare is going to happen in the next 15 to 20 years. So with that, they're again pushing quality value programming. And again, if you look at a biosimilar that is equivalent to the biologic that is less costly, by definition, that biosimilar offers a better value. That better value fits exactly into what Medicare and insurers are trying to move us forward in the future. So there's a lot of pressure to use less expensive therapy in healthcare today, and these drugs fit the bill perfectly.
How much freedom do providers have to pick the biosimilars they want?
In general, we usually, again, until the insurer starts to pick preferred agents, we can pick between the agents available. You look at the contract, you look at the company, you do a very thorough evaluation, and all this is done through the P&T committees of institutions. and health systems. And again, people will look at the product, at the provider, the company. What is their record? How much do they, how much drug do they have? Are they going to be able to meet our needs? What kind of contract can we get? So in most cases, providers can choose what they want to use based off of, will this be paid for? One of the problems that people don't realize, we cannot bring in a drug into our institution unless it gets paid for. We can't give out free drug. So it's always interesting when drugs get approved that you have to check with your payers to see, are you going to pay for this product? And if you will, in general, we would love the insurers. I think the insurers are actually causing one of the biggest hurdles now in institutions using biosimilars. If all insurers would basically do this by parity, basically, if they can say, yes, you need to use a biosimilar before the originator, but you pick which one you want. You have the ability to pick the one you want. That's called parity. That's what we're looking for. Yes, we would love to use a biosimilar. We don't need to use the originator, but let me pick which one fits best for our situation, for our circumstance, within our GPR purchase group, within our, again, if we have 340B institutions, there are difference in prices. There's all kinds of variables that can make one institution pick one agent over another, but we think we are smart enough to be able to make those decisions and not have the payers make them, the insurers make them for us.